Yeah.
Yeah, Dr. Rishikesh Mayee, he is a renowned pediatric ophthalmologist from Nagpur. He is a very good strabismologist and amblyopia consultant also in Nagpur, means in center of the India place. He is a wonderful. He is going to present on limber approach of lensectomy for congenital cataracts.
Thank you, sir. At the outset, I would like to thank SPOCI for this wonderful opportunity. I'll be presenting a limbal-based approach for lensectomy for congenital cataract. Actually, I mean, pars plana lensectomy is quite well known, and as everybody is aware that pars plana lensectomy becomes easier, especially for retinal surgeon, and with the risk that the uveal tissue, especially the iris, will not be damaged. However, it needs lot of expertise and also instrumentation. So Kansky et al. They came out with a technique for limbal approach for removing the lens. Everybody is aware that if the corneal diameter is less than 10 millimeters, you cannot put a lens. However, for congenital cataract, the best time to operate is unilateral cataract is less than 4 weeks, and for bilateral it is around less than 6 weeks, not only for giving vision but also binocular vision. But we cannot put lens in all these cases, so we simply need to remove the lens by using a vitrectomy. I'll just show the video, but before that, counsel the patient very well, counsel the parents very well. Counseling is most important part actually, because we need to tell the parents that surgery is just the beginning of the treatment, not the end. Actually, it is a long path of visual rehabilitation, which includes glasses, contact lenses, and a secondary oil later on. Also, the frequent follow-up, frequent application of drops is very important. And in spite of everything, in spite of your best effort, the visual outcome may not be as desired. So preoperative preparation includes various investigations, especially rubella. Try to rule out rubella in these cases because it might have cardiac side effects as well. So get a fitness from pediatrician and pediatric cardiologist. I usually send all my cases to the anesthetist beforehand, before the surgery, not on the day of surgery. And bilateral surgery, it's still a debatable topic, but if there is a risk of anesthesia, a bilateral lensectomy can be done. The video which I am showing, actually I did a bilateral lensectomy in this case. This was for the right eye. You go with the side port entry the way you go for adult cataract, and don't use viscoelastic agent. Just put a irrigation cannula. This is an unedited video actually. So irrigation cannula, and then with a 23 gauge vitrectomy. This was from Intuitive machine by Johnson and Johnson. No financial interest. In this machine there are two settings. One is irrigation cut aspiration, and the other one is irrigation aspiration cut. So initially you go with irrigation cut aspiration. Use minimal aspiration and minimal cut, right? Because we are going to create an opening in the anterior lens capsule. The calcified portion might be a bit hard, so in that case you can increase the cut rate to around 200 to 300 per minute. But initially don't try to remove the lens matter unless you are through with the anterior lens capsule. So create a large opening, because if you have to put a secondary IOL, we will be putting using the the capsular rim only. So also if the anterior lens anterior capsular opening is small, you might have a capsular fibrosis later on. So create a sufficiently large anterior capsular opening, and then we can go to irrigation aspiration and cut, because now we are going to remove the lens cortex or the lens matter. In pediatric cases, we don't leave behind the fibers. I mean, the lens fibers or cortical fibers are not seen the way we get in adults. So usually the lens matter, it comes out en bloc. So it's quite easier to remove this part, especially on the side opposite to the cutter. uh, uh, Ensure that you have removed all the cortical matter. No, don't leave behind any cortex at all. This is an important step, because you are likely to touch the iris here, and you are likely to leave behind the cortical matter, but both of these situations will increase a lot, will cause a lot of inflammation. Anyway, pediatric eyes are more prone for inflammation, so don't touch the iris, and also remove the cortex in totality. The problem comes with the subincisional cortex here. We might be have a tendency of switching the ports. I mean, go with the vitrectomy on the other side, but don't do that, because the moment you come out with the instrument, the globe is likely to collapse because the pediatric sclera is thin and the globe is collapsible. So basic part about this surgery, once you enter with your instruments, complete the surgery and then only you come out, so that there won't be any collapsing of the globe, no prolapse of the vitreous into the anterior chamber. Uh, once you have got rid of the cortex, then you create an opening in the posterior capsule. Again, you go with irrigation, cut, aspiration, minimal cut and minimal aspiration. Remove the, do the posterior capsulotomy only and only once you have removed the cortex. Otherwise, the cortex might, fall into the vitreous cavity. Uh, Once the posterior capsulotomy should not be more than around 5 millimeters. It may not be as large as the anterior capsulotomy. Once you have done the posterior capsulotomy, you can increase the cut rate to around 800 to 1000 per minute when we do the anterior vitrectomy. Do a thorough anterior vitrectomy, remove the anterior vitreous phase, because even that can act as a scaffold for posterior capsular opacification, which might cause a media opacity, and ensure that there is no vitreous prolapse into the anterior chamber. And at the end of surgery, when you remove the cutter, you keep the irrigation cannula on, and then you do the hydrate. Then you hydrate the side port so that the globe doesn't collapse and the vitreous doesn't come into the anterior chamber. Also, we inject dexamethasone in the conjunctivally. If you feel there is any, if you have any doubt about the wound integrity, you can apply suture here, because the globe is collapsible. So applying 10-0 Vicryl suture may be a good idea. On table itself, you do a refraction and check for the fundus and prescribe the glasses accordingly. Early post-operative treatment includes steroids, which are given regularly, 1 hourly, and antibiotics. You might have to give oral steroids also. Syrup Predone, again, no financial interest, is available. You can give it 1 milligram per kg. Follow up the patient on the first day, third day, and look for AC integrity and AC reaction. At 3 months, you measure the intraocular pressure and measure the corneal diameter under anesthesia. And if it is more than 10 millimeters, you can apply a secondary IOL, usually around 1.5 to 2 years of age. Remember that when you are prescribing the glasses, you overcorrect, because we want the child to see for near clearly. So 2.5 to 3 diopters more than what you have got the reading on your retinoscopy has to be given. So the important point from literature search is that there is no significant difference between the visual outcome and complication rate with limbal lensectomy versus pars plana lensectomy. The basic thing is that earlier surgery is more important for better visual outcome and lesser chances of post-operative complication. When I was doing my fellowship in Shankar Netralaya, we conducted a study to find out what are the predictors of glaucoma following surgery for a congenital cataract. It was published in Eye, and we found that the younger the age of surgery is the most identifiable risk factor. So the earlier the child gets operated for congenital cataract, more is the risk that he might develop glaucoma. Thank you. Thanks.
Thank you, Dr. Rishi, for wonderful presentation. I just want to what you said, when you are taking out the instruments back, there will be eye collapse. So in our institute, we have developed a wonderful technique which we keep it as a AC maintainer. So if you put AC maintainer, you don't have to worry about that, if any case you have to do. And all of them may not have retractors with them, so they can definitely go for Rexis, but the only point you need to take care, it's not an adult Rexis, it's not an adult capsule. It will not behave as an adult, it may go off anytime, so your good hand control is must. Thank you so much.
Dr. Mayee, your video was excellent. Your surgery and surgical skills are really excellent.
Excellent.
I would like to ask you 1 or 2 questions. One question is it necessary to perform posterior vitrectomy all the time?
Yes, sir.
Anterior vitrectomy.
Antivitrectomy, yes, sir. Not only that, the posterior lens
Because
capsule.
there are 2 schools of thought. Some
Yes,
people
yes.
are doing it or some people are not doing.
No, but I would always do an anterior vitrectomy, because even the anterior vitreous face can also act as a scaffold for capsular opacification, which might obstruct the visual axis.
Good
So we
point.
have to do that.
But one more thing I have observed in your case, there were certain calcified spots over the anterior capsule.
Yes, sir. Yeah, there were. In this case, it was there.
It is said or this was the finding of Dr. Daljit Singh, and these are known as DS spots. If you find any calcified spots over the anterior capsule, that means the posterior capsule is already absorbed. Already there is a, and vitreous is already open. These spots, they indicate like that. These are known as DS spots. I don't know whether that is correct or not, but this has been, there was one paper in our IJO that you have to, in all such cases where you will find any calcified spots over the anterior capsule, you might be in trouble. Take care that you have to tackle the vitreous also.